So coming to cardiac manifestations, there will be hyperdynamic circulation that we have already seen before. So there will be increased cardiac output. Though there is increased cardiac output, this is not reflected because all this volume is getting sequestered in your splanchnic vasodilated vascular bed, and so the actual effective circulatory volume is decreased. Okay, and so there is lower arterial BP and there is also lower SVR. And added to this, the portal hypertension causes release of vasodilatory substances like your nitric oxide, natriuretic peptide, endotoxins, and glucagon. All this cause decreased circulating response to your sympathetic stimulation. So on one hand, though there is hyperdynamic circulation, the arterial BP remains low. And also there is no increase of BP because there is no response to your sympathetic stimulation due to this vasodilator substances. So there is a condition called cirrhotic cardiomyopathy, which consists of increased cardiac output and decreased peripheral vascular resistance, both systolic and diastolic dysfunction, your cardiac resistance to beta adrenergic stimulation, and electrophysiological abnormalities. So these four are the components of your cirrhotic cardiomyopathy. Please remember, increased cardiac output, both systolic and diastolic dysfunction, electrophysiological changes, and resistance to beta adrenergic stimulation. So this increased cardiac output is due to your increased hyperdynamic circulation and also decreased afterload. This systolic incompetence, how we will know, is by physiological or pharmacological stress test. Okay, so there will be no increase in cardiac output in response to these stressors. It's systolic incompetence. And coming to diastolic dysfunction, we'll be knowing it in 2D echo. There will be ventricular resistance to diastolic filling, septal and left ventricular hypertrophy, and they are more vulnerable to heart failure. There is also autonomic dysfunction in these patients, and that will be knowing by challenges such as your sustained hand grip, ice water hand submersion, tilt table testing, etc., which we'll be doing in diabetics also, right? And they are more prone for arrhythmias like AF, SVTs, and also they'll be having QT prolongation. So please be careful with the drugs which prolong QT. And this arrhythmias may be aggravated by your sympathetic stimulation during your surgery or acid-base imbalances or your electrolyte abnormalities. So please maintain all of them in a normal range. These patients are also prone for your CAD. Okay, so we have to look for risk factors like your hypertension, diabetics, family history of CAD, cigarette smoking, hyperlipidemia, and if they are more risk for a CAD, we have to go for a coronary angiography before a surgery. So these are on my gross your cardiac manifestations. Coming to CNS manifestation, which is your hepatic encephalopathy. Hepatic encephalopathy is three types: type A, type B, and type C. Let us see the types first. These are your types. Type A is encephalopathy with acute liver failure. Type B is encephalopathy with portosystemic bypass. Here there is no intrinsic hepatocellular disease. There are portosystemic bypass. And type C, it is cirrhosis. So A with acute liver failure, B with bypass, that means portosystemic bypass, and C with cirrhosis. So what is the spectrum of this hepatic encephalopathy? It may range from minimal to the overt. In the minimal, we can diagnose only by psychometric test, but in overt hepatic encephalopathy, the symptoms and signs are clearly evident. There will be neurological and behavioral derangements in the person. And this hepatic encephalopathy might present in acute liver failure or chronic liver disease. And the main thing is it is frequently reversible. So we have to be vigilant. If we diagnose it fast, we can reverse it fast. Okay. Type B, we have already learned that the liver function is normal. There will be bypass or shunts. So the diagnosis might be by neurophysiological criteria or neuromotor criteria. Here we focus on the level of consciousness, the attention, and whether he is able to follow your commands or not. On examination, what we'll be seeing is if there is clonus, asterixis, Babinski sign, nystagmus, decerebrate posturing and all. But we have to rule out structural neurological lesions because these patients are more prone for IC bleeds also. So the neurological derangement is because of either IC bleed or the actual hepatoencephalopathy, hepatic encephalopathy. We have to differentiate. We have a criteria for grading of hepatic encephalopathy. We all know that that is West Haven's criteria, which is a separate question too. So there are four grades. Starting grade one, just trivial lack of awareness. Patient might be in state of euphoria or anxiety, shortened attention span, impaired performance. And grade two will be lethargic and apathy may be present and minimal disorientations, minimal subtle personality changes, inappropriate behavior, and impaired performance of subtraction. And grade 3, somnolence to stupor, semi stupor, but there will be response to verbal stimuli. There will be just confusion, disorientation. But grade 4, no response to stimuli, almost it is coma. So, how this liver failure is affecting your CNS. Let us see. Liver failure, what happens? There will be inadequate metabolism of substances, right? For example, your ammonia, GABA agonist, there will be inadequate metabolism of these substances, and also in addition to that, there will be oxidative stress, inflammatory mediators, etc. Right? So, first, if we take ammonia, which is the major thing causing your hepatic encephalopathy, normally what has to be done? This ammonia has to be converted into your urea or urea cycle. If the liver functioning is normal, if there is cirrhosis or liver failure, what happens? This ammonia gets accumulated and your brain or skeletal muscle cannot convert this ammonia into urea. Brain has in its astrocytes, it has glutamine synthase enzyme. So it takes this ammonia and along with the glutamate and glutamine synthetase enzyme, it forms glutamine. Okay. So what does this glutamine does? In liver failure, increased ammonia, increased glutamine is present. This is osmotically active and pulls the water intracellularly and causing your astrocyte swelling and finally leading into cerebral edema. And also the glutamate, which is being released to combine with ammonia, it has excitatory effect. So there will be neuroexcitatory signs such as agitation and seizures. Okay. So what happens? There is increased ammonia to metabolize this. With the help of glutamine synthetase enzyme, it combines with glutamate. So final product is glutamine. So both is glutamine and also glutamate are causing your symptoms. Glutamate because of its neuroexcitatory thing, and glutamine it causes cerebral edema. And apart from this, there might be another reason is in liver failure, there will be failure to synthesize substances which are critical for normal neurotransmission. So, certain substances are not being synthesized and certain substances are not being metabolized. Both these are the reasons for your CNS symptoms. Okay. So, generally, we have seen that there will be excitatory component. But in type C, that is neuroinhibitory type. Okay. This is because there will be chronic adaptive changes that include your downregulation of glutamate receptors and also inactivation of astrocyte glutamate transporters. So this is reverse type. Okay. So more of GABA addict tone. That means something similar to your benzodiazepine like substances. So this might be treated with benzodiazepine antagonist flumazenil. But its usage, of course, is limited because we might not know the entire pathogenesis and all. So for this, just remember type C is neuroinhibitory and type A is neuroexcitatory. What is the main problem is your glutamine and glutamate. All this is because of your ammonia. So how we will treat this? Is mainly the most important thing is you have to control the precipitating causes. And once there is hepatic encephalopathy, we'll be going with oral lactulose 8 hourly, non-absorbable antibiotics like your rifaximin and neomycin and zinc supplementation because it also helps in urea cycle. And LOLA, which is nothing but L-ornithine L-aspartate, it also helps in the metabolism of ammonia to urea. So all our treatment is focusing on metabolism of ammonia, right? So your LOLA or zinc, we can go for oral lactulose and all. But the main thing is you have to avoid the precipitating causes. Let us see the precipitating causes. Constipation, dehydration, GI bleeds, bowel obstruction, any infection, electrolyte imbalances like hypokalemia, hypoglycemia, hypothyroidism, hypoxia, metabolic alkalosis, anemia, uremia, hepatic malignancy, vascular occlusion, and transjugular shunts. Generally, shunt is a treatment, but it might precipitate your hepatic encephalopathy. So we have to be careful. So hepatic encephalopathy, the main things is due to ammonia. It is not being metabolized. It is metabolizing into your glutamine with the help of glutamine synthetase and the glutamate. So it is causing neuroexcitatory effects. But type C is neuroinhibitory. We'll be treating it with, we have to avoid the precipitating causes. Oral lactulose, rifaximin, Lola, zinc. Okay.